you began the conversation by talking about the tremendous burden of uncompensated care. What happens to that?
Well, I think from an economic standpoint, if you lower the uncompensated care, and I should say that even in our plan, everyone wouldn't be covered because it's America, and even if you had an individual mandate, there would still be issues of compliance. But if most people were covered, it means that hospital finance would change radically, I think, because you wouldn't have to rob Peter to pay Paul that goes on now in hospitals. And also I think when people come in, everyone has insurance, basically. Maybe a few don't, but basically everybody does. It reduces your intake costs. It reduces a lot of the dealings that have to go on between patients and hospitals regarding the financing side, because you're just going to copy the insurance card and basically process them in. So I think in terms of the relations between patients and hospitals, it'll make it easier, simpler, and people can focus on the health and medical side of things and not have to worry as much about the financial side. In terms of the finances of hospitals, I think it will remove the necessity to have all this indirect subsidization. And so I think in terms of the amount that hospitals end up working out for payment with insurers and with Medicare and with Medicaid in the states, I think it'll lead to a lot clearer understanding of what true costs are in hospitals, and I think probably more efficiency.
But still unlikely that a single organization's plan would drive this very large debate. So what do you think needs to happen in the next year or so for real movement to be made, either on your plan, someone else's plan? Do the traditionally warring parties need to sit at the same table? Is that under discussion?
I think that's a much bigger question. I mean, we put our plan out there as a marker to say that with the ingredients of the current system, we can have universal coverage, and to sort of show how that could be done. In terms of actually getting something done, I think that is a very difficult one. I think there have to be a number of ingredients. I mean, first, to do anything, whether it's universal coverage or at least significant change, you've got to have presidential leadership. You've got to have the will in the White House to work through the legislative system a major change in how health care is financed, and I would argue probably you'll get into how health care is delivered, because the health care cost issue is going to be part of the package, as well as the appropriateness and quality of care that's being provided to people who hopefully be now covered under any plan. So that's one ingredient you've got to have. Second, I do think in terms of the outside world, the Main Street America, the sun and the moon has to come together. I mean, employers and consumers and labor and, I mean, those who would pay the bill and those who would receive the coverage all have to come to some kind of general consensus, or at least a majority of them, that something ought to give here, something ought to happen, so that the legislators will have the political will to do things that will
that they understand the different parties could agree on.
Well, could it agree on, or at least come to some consensus on? I almost would rather use the word consensus than agreement, because I don't think that everyone's going to get their ideal solution. And I don't think everyone's going to be 100% happy with the outcome, but I think if they are satisfied that it was worth the journey, and that overall it's better for the average American and everyone who's paying the bills, I think that's the kind of outcome we'd want to seek.
And where would the Federation draw the line in the sand? Where would you be willing to move to reach consensus, and where would you be unwilling?
Well, you know, one is always reticent to negotiate with themselves. But I think from the standpoint of hospitals, the rub comes on the financing side, obviously, because the issue is going to be, if we're going to cover everyone, if we're going to have universality through whatever model you choose, and there are many models, or if we're going to cover a significant number of Americans, policymakers are going to look back at hospitals and say, well, what are you going to contribute? And if we look at Massachusetts, for example, there was an indigent hospital fund in Massachusetts of many hundreds of millions of dollars that was used to help fund some of the insurance purchasing under the Massachusetts model of healthcare coverage that's now in place. So I think, and also if you look at California and the debates there are tremendous problems in California with Medi-Cal, Medicaid payment in California, and the governor wanted to put on a hospital tax as part of his package, and so there were things worked out there. So at the end of the day, whether it's disproportionate share payment, payments that are made under Medicare or Medicaid for hospitals treating sicker, poorer patients, or other kinds of subsidies that hospitals get right now in existing programs, I think people are going to look at hospitals and say, okay, how much of that are you going to give up? And part of the issue will be, the balancing act will be, are we going to see enough covered people through the reform that it will balance out and hopefully be a little bit more than whatever would be lost if there are changes. Obviously, we're not advocating any cuts in hospital payment, but if we're realistic, those are the kinds of things that will be discussed.
A final question. As you know from having worked in Washington for as many years as you have, there is a cyclical nature to the conversation you and I are having. Yeah. Is this time any different?
Probably. Well, there's specific aspects of it that are different. I mean, I think we're at a point now in the development of the healthcare system where I think we know a lot less or have to be less confident about the model for reform than we might have been in the early 90s. If you go back to the early...
You know less now?
Right, right. I think if you go back to the early 90s, both the private sector and Medicare had come to a point, and I think the healthcare intelligentsia generally, had come to a point where some version of managed care was accepted, health maintenance organizations, whatever, as an organizing center for delivery that also would play a role in more efficient and maybe more effective financing of care. And the organization of how to get from point A to point B in healthcare coverage, I think there was a lot more confidence about. So whether you were on the right or the left, you sort of accepted that. Now, obviously, in the Clinton care, they wanted to use the alliances as the ways that private managed care and HMOs would market themselves, and there was great disagreement about how that would work. But I think there was a paradigm that efficiency and cost effectiveness could be brought about through this integrated delivery organizing. And the fact is, other than a few HMOs around the country, I'm not sure it was ever as integrated or organized as people thought. And as you go through the 90s, you know, it's interesting, 96 is sort of the key year. There were very few premium increases in 96. It was the most effective year, in a sense, for managed care controlling costs. It also was sort of the key year when patient protection and concern about aspects of managed care were bothering the consuming public. And now you see a system that we can call a lot of different things, other than a few places around the country that have old-style HMOs, is really sort of a fee-for-service kind of system. And even with the great understanding now, I think, that was so focused with the Institute of Medicine a few years ago, raising the quality issue and raising the issue of integration in of healthcare for the average American, we are further, I think, from having a model as to how to make changes. I mean, many of us are involved in much more measurement, and there's discussion of comparative effectiveness of therapies, but there really is no, I would argue, organizing model that we could generally accept that would show us how to get from point A to point B, other than this old insurance model in terms of getting coverage that's out there. So I am extremely worried that the infrastructure is not well suited for reform. That's one thing. Second, we all are in agreement, I think, that changes in our system, better care for chronically ill Americans, really, and other aspects of change and improving quality really depend on primary care. And if anything, our primary care across the country has deteriorated, not because we don't have good physicians or nurse practitioners, but because we don't have enough of them. And if everyone was covered, this is something that's come out in Massachusetts recently, if everyone was covered, I'm not sure the primary care practitioners would be there. So I think that things have changed, and I'm not sure for the positive, in terms of the infrastructure. before you even get to all the complexities of health reform.
The Kaiser Family Foundation presents Health08.org, election news, analysis, and events.